Hello, once again, ladies and gentlemen. This will be the first of two talks on the basics of dermatology. Now, I want to talk here, when I say basics, I mean pretty much just talking about what normal is. Now, as a physician, I really cannot restrict myself to normal. So I will talk about a couple abnormal disease processes, a few of them, but I'm not going to go into the details and the management and stuff. I just want to make this kind of relevant to you. But really, it's important to get the foundations down anytime you're studying for an exam or really just for general practice, because a lot of students go into studying for USMLE and they think I just need to remember the disease processes, and that's true. That's most important. But really, at that point, you're just memorizing stuff. You got to know what normal looks like. And if you have a really good foundation on what normal is, it's really going to help you understand abnormal, because otherwise you're just memorizing. If you know what normal is, it's going to make abnormal, it's going to make disease processes, management, and everything like that sink in a lot better. So I really strongly suggest, if you're taking step one, all of this is going to be relevant for you. If you're taking step two or three, or you're reviewing for clinical practice, then a lot of this is going to be kind of review, but it really will help you as you go forward with the dermatologic diseases to have that foundation and to start with that, and then helps make these diseases make more sense. So I'm going to try to keep this talk under half an hour, but don't quote me on that. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking on the I button on the upper right-hand corner of your screen, or on the link below. There's in the description of the video, I put a link. So if you subscribe, you'll have access to some of my premium videos in which I go over case studies, formulating differential diagnosis, and treatment plan, things that will come in handy for you for step 3 as well as for clinical practice. Just $1 a day, or $1 a month rather. $1 a day would be nice, but $1 a month really just helps keep these videos coming out and helps keep them free. So thank you very much in advance for your consideration. I appreciate it. So we're going to talk about the epidermis, dermis, dermis-epidermal junction, and the hypodermis. Basically, we're going to talk about skin in this talk, and then in the next talk, we'll talk about some of the accessory structures. So what is dermatology? Dermatology involves, but is not limited to, the study, research, and diagnosis of normal and disorders, diseases, cancers, cosmetic, and aging conditions, and this is the kicker here, of the skin, fat, hair, nails, and oral and genital membranes. So it's not just skin. Dermatology is not just skin. If you've got a patient who's coming in with some weird pattern of hair loss, or discolored nails, or some unusual issues going on with their hair and nails, stuff like that, you're going to send those patients off to a dermatologist if you don't know what's going on. So dermatologists deal with a lot more than skin. Certainly skin is the foundation of their practice, but they deal with hair and nails too. So dermatology is not just the skin. However, this talk we're going to primarily be focusing on the skin. In the next talk, we'll be talking about hair and nails and some of those accessory structures, sweat glands, and stuff like that. So the epidermis is the most superficial layer. The primary cell type, the predominant cell type, is keratinocytes. They make up over 90% of the cells in the epidermis. Now, normally when somebody will say a skin cell, it's not the right word, but they're talking about a keratinocyte. So epidermis is your most superficial layer. When you look at somebody's skin, you're looking at their epidermis. There are 5 layers of the epidermis, and I probably should have given you some kind of mnemonic to remember this. I don't know any. This is, when I was in high school, I took physiology, and I just dedicated this to memory, and that's the only reason I know it. I don't have any mnemonic for you, unfortunately. If you know one, put one in the comments below. I'd really appreciate it. So I'm going to work here from deep to superficial. So the deepest layer of the epidermis is the stratum basale. And that is just a single layer of cells, and they're cuboidal epithelial cells, and they're important for 2 reasons. One, they provide the stem cells for regeneration of other more superficial layers, and so all of these keratinocytes, they migrate to the top and then ultimately are sloughed off as the cells die. And so these aren't unique cells at each layer. They're the same cell, they just progress more superficially. So at the base of the epidermis, the stratum basale, you've got cells that undergo mitosis, and they provide regeneration for the other layers. The other reason that the stratum basale cells are important is because they anchor the epidermis to the underlying basement membrane, and that's going to be really important when we talk about one of the diseases. Also, part of the stratum basale are the melanocytes. These are pigment-producing cells. They're derived from the neural crest cells, and that's separate from the keratinocytes, which are derived from just general ectoderm. The next layer up is the stratum spinosum, and these are irregularly shaped polygonal cells, so a little bit flatter than the cuboidal cells of the stratum basale. These cells in the stratum spinosum are linked together by desmosomes, and desmosomes just link cells together. They also contain lamellar granules, and inside those lamellar granules is a lipid-like substance. Now, as these cells migrate superficially, then you get to the stratum granulosum. And the stratum granulosum are flattened epithelial cells. So they're a little bit flatter yet than the cells of the stratum spinosum. And at this point, these cells will have released the lamellar granules. And so that fat substance, that lipid-like substance, will now fill the space in between the cells. So you don't really need those desmosomes anymore. And the nice thing about that fatty substance that fills the interstitial space is that it's a fat, and so it repels water. So this is why when you go and take a shower, your body just doesn't puff right up, and you get water inside your organs and stuff like that. So this repels the water. Now, obviously, you've got layers that are more superficial to this. So when you use lotion and moisturize, it does get into your skin, and it does help you retain some water, but the water doesn't go any further. Moisture doesn't go any further than the stratum granulosum. The stratum lucidum is a very discrete layer that's only seen in thick skin. Note that I say it's only seen in thick skin. It probably exists elsewhere. These are dead cells. So these cells have lost their nucleus. These are dead cells. Everything below this, these were alive cells. But these are dead cells in the stratum lucidum. And you're really only going to see this in thick skin. I'll show you a picture of that. And then the stratum corneum, these don't even look like cells anymore. So this is just pretty much, as far as it appears, just keratin with some lipid material surrounding it. And so as far as the epidermis goes, this is the layer that plays the most important role in protection. The epidermis has no vascularization or innervation, so it needs to get all of its nutrients from the dermis that's underlying it, and I'll show you how that happens. So going back to the stratum spinosum with the desmosomes, you really need to remember stratum spinosum and desmosomes. So these are the desmosomes right here. You can see that they connect the cells to one another. Okay, so this is kind of a 30,000 foot view of the skin, and so here underlying this paler layer here, this is the dermis, and then this darker staining layer here is the epidermis. Now we're going to look more closely at these layers here. So here we got dermis underneath, and then the stratum basale, which is the one cell layer of cuboidal epithelial cells that, remember, attach the epidermis to the basement membrane and also provide stem cells for regeneration. Then you got the stratum spinosum. Remember, they're linked together by desmosomes. They're usually a couple layers thick. And then the cells become more flattened. And then this is the stratum granulosum, these more flattened cells, but they're still alive. They still have nucleus. Stratum lucidum, you're probably not going to see here because this is thin skin, but I got a slide in a little bit that'll show you the stratum lucidum. And then the stratum corneum don't even look like cells. They just look like keratin and fat material. And this is what you see when you look at somebody's skin. So here is the difference between thin skin and thick skin. Two major differences. I mean, yes, in thick skin you're going to have more cell layers, but that's not the major difference. The major difference between thin skin and thick skin is that thick skin is going to have a stratum lucidum, which is distinct from the stratum granulosum in that it stains a little bit more pale. But the stratum granulosum, remember, these are cells that still have their nuclei. The stratum lucidum do not. And then the stratum corneum. The big difference between the layers, the stratum corneum layer in thin skin versus thick skin, is that in thick skin, not only is the stratum corneum somewhat thicker, but the keratin is just much denser. So notice here that it's kind of fluffier and looser. Here it's just very, very dense keratin. So thin skin may be found on like your face or the scrotum. Thick skin is going to be like your heels and your palms and stuff like that. Okay, so this is, if you look here at the stratum basale layer here, you see keratinocytes, these cuboidal cells, but then you also see these little cells that kind of look like little eyeballs, and these are your melanocytes. And you can see this melanocyte here, there's some pigment granules around it, and these pigment granules, which contain melanin, are going to be incorporated by the keratinocytes. And so everybody, regardless of their skin color, has the same number of melanocytes. The difference is how active their melanocytes are. So someone like me, who's of Swedish descent, very pale skinned, my melanocytes are basically dormant, and that's why I get sunburnt all the time. You take somebody from Cameroon though, and they've got the same number of melanocytes, they're just churning out melanin at a much higher pace. Okay. So some diseases of the epidermis. Big one is pemphigus. And pemphigus, for some reason, comes up a lot on the USMLE. I don't know why. But pemphigus is actually a family of diseases. And these are autoimmune, but the big thing is that they form blisters. And there's a lot of blistering diseases. And pemphigus is one of the ones that you really need to know. But you're going to want to know how to differentiate these blistering diseases apart from each other. And so it helps to know kind of the etiology. So with pemphigus, the thing that they all have in common is that they all involve destruction of the desmosomes. Now this is autoimmune, so what type of hypersensitivity is it? It's a type 2 hypersensitivity. And so you've got antibodies against the desmosomes. Remember that this desmosomes are linking the cells in the stratum spinosum. And so what happens is that these cells now become loose and displaced. And so now you have potential space in between two layers, the stratum corneum and granulosum, and then everything underneath the stratum spinosum. So you've got a fairly weak dome to the blister, only 2 layers, and that's going to stand in contrast to another blistering disorder that we're going to talk about in a little bit. So Pemphigus vulgaris is the most common cause. It also involves other mucous membranes, such as that of the mouth, esophagus, and vagina. These are painful blisters, typically comes on middle age. You'll see this with more frequency in Ashkenazi Jews, and this 99th percentile information specifically involves a protein called desmoglein 3. Psoriasis is also autoimmune, but it is not blistering. It's characterized by patches of abnormal skin. Usually these patches, sometimes plaques, are dry, red, itchy, and scaly. And it's due to excessively rapid and premature maturation of keratinocytes, which ultimately does have an autoimmune basis to it. It can occur anywhere, but has a predilection for forearms, shins, and scalp. Okay, so pemphigus. Here's Pemphigus vulgaris, and you can see here that you don't see a lot of blisters. Now, all of these lesions came from blisters, but the blisters don't stick around too long. Why? Because they're weak blisters. They're very fragile blisters. So as soon as you develop a blister, it's probably going to burst and desquamate. And so what you see here is a lot of exfoliation of the skin. And so that's Pemphigus vulgaris, and that's going to stand in contrast to something we'll talk about in a little bit. I'll see. Here you can see it on the oral mucous membrane. This is psoriasis, obviously not a blister. These are just these patches of abnormal skin. It tends to be kind of thick, reddish, pinkish skin that has got some scaling on it. It really itches, and if you kind of scratch at it, you'll get flaky stuff falling off of it, not much unlike dandruff. And so this is psoriasis. Now, psoriasis can also come in plaques. So notice all the normal skin around it, and then boom, this plaque of psoriasis. Again, sort of reddish, pinkish, with this white, scaly-like material, and that's just keratin. But this is plaque psoriasis. And then you can see here even more dramatic, lots of scaly keratin. And like I said, has a predilection for the forearms, shins, extensor surfaces. Some more diseases of the epidermis. So oculocutaneous albinism, most common cause of albinism. This is an autosomal recessive disorder of the melanocytes, and it's actually an enzymatic defect. The enzyme is tyrosinase, and tyrosinase converts tyrosine, the amino acid tyrosine, into a precursor of melanin. So if you can't do that, you can't make melanin. And so these patients are going to be completely depigmented. Now, it's called oculocutaneous. It also affects the eyes, and melanin plays a role in the development of the ocular system. I'm not going to go into the details of that, obviously. It's beyond the scope of the USMLE. It's beyond the scope of my talk. But do know that patients who have albinism also have eye problems, various eye problems. Vitiligo is an autoimmune disorder resulting in a localized destruction of melanocytes. And again, this often comes on, middle-aged, maybe a little younger, maybe a little older, but it's autoimmune. And it results in depigmented patches. So it doesn't just, you don't turn into an albino with vitiligo. You get little patches, and these patches can grow with time. They're most noticed around the bodily orifices, so think like around the mouth, around the nose, around the eyes, around the genitalia, and so that's where you're going to see it the most. It is associated with other autoimmune disorders, so somebody who comes in may have a history of celiac, Hashimoto's, lupus, or they may develop that down the road. Okay, so here's albinism in a baby. You can see this is a Caucasian child. The skin doesn't look terribly abnormal. And remember, they don't have just totally pale white skin. You do see a little bit of color, but that color is only coming from the blood vessels underneath. They have absolutely no melanin. Where you really notice the abnormality is the hair color. This is not a normal color hair for a baby of any race whatsoever. So this is no melanin in the hair follicles and the hairs. And the reason for that is because they can't make melanin. Now, older people will get this too, but that's a natural process with age. You can see that the iris are a little bit red. That's something that you may see in albinism too, but not in everybody. So if you look at this child, you don't see any red eyes, but you do see the very, very fair skin and most prominently the white hair. Now, albinism is going to be more dramatic appearing in somebody of color. So you can tell this is somebody of African descent based on the wide nasal bridge and the texture of the hair. But you can see her skin color does not correspond at all to somebody of African descent. Now, this is albinism here. She probably colors her hair. This would be, I don't know, this would be slightly, maybe a little bit darker than you'd expect with somebody who's got albinism. Yeah, obviously not a natural hair color for somebody of African descent in any case. And then here's vitiligo. You can see the patches tending to congregate around the bodily orifices. It could happen around the eyes too. Again, something you're going to see a lot more dramatically in someone of color for obvious reasons. You can see it in white people too, but it's just not going to be as obvious. And you do need to differentiate vitiligo from certain fungal disorders, which can cause depigmented patches. Okay, the dermis is a dense, irregular connective tissue composed of fibroblasts, adipocytes, and macrophages, as well as a couple specialized nervous structures. And it's divided up into two layers. The papillary dermis, which is more superficial, it's looser, still collagen fibers, and it interdigitates with the epidermis. And do I have a picture? Yeah, so here you can see this interdigitation with the epidermis. So you can see how it kind of comes up and down and up and down. There's a name for that. So with the epidermis, these little projections here, these are called rete ridges, R-E-T-E, rete ridges. And then the equivalent of the dermis that comes up into the epidermis, these are called dermal papillae. And so together they are forming what we're going to see is the dermis-epidermal junction. Within these dermal papillae are capillaries, but also these important structures called Meissner's corpuscles, which are specialized nerve structures that are responsible for perceiving light touch. The reticular dermis is deep, it's denser, but still connective tissue. It houses the hair follicles, sebaceous glands, sweat glands, and blood vessels, things we'll talk about in the next talk. It also contains Pacinian corpuscles, which respond to pressure and vibration. So it makes sense that those are deeper. Light touch is going to be more superficial, and pressure and vibration is going to be deeper. So just remember Pacinian and pressure, same letter. The orientation of the fibers in the reticular dermis is what gives rise to the famous Langer's lines, which are really important for surgeons when they make their incisions. They'll try to make them along Langer's lines that will help with healing and reduce the risk of like keloids and stuff like that. The dermis is of mesodermal origin. So remember, the epidermis was of ectodermal origin. The dermis is of mesodermal origin. Okay, so this is a Meissner's corpuscle right here. You can see, you don't see one in these dermal papillae, but you see one right here. It kind of looks like a little beetle right here. That's a Meissner's corpuscle, also known as a tactile corpuscle. So here's another one, a little bit less obvious. And again, they're in those dermal papillae, those little projections into the epidermis. This is a Pacinian or lamellar corpuscle, which respond to pressure and vibration. And these are really obvious. They're very deep in the dermis. You can see they come all the way down to the hypodermis, or close to it. And they're very obvious because they look like onions. So you can see here this kind of onion skinning. Again, right here, very, very clear. All right. Now, at the dermis-epidermal junction, remember we talked about that. That's those interdigitations between the rete ridges and the dermal papillae. In between the dermis and epidermis is a very thin basement membrane. And we kind of already alluded to that basement membrane. That's how that's where the stratum basale attaches with hemidesmosomes onto the basement membrane, what anchors the epidermis to the rest of the body. But also underneath your basement membrane is your dermis. So there's a basement membrane that separates the epidermis from the dermis. Now, very important, remember those hemidesmosomes that attach the stratum basale to the basement membrane. You can get an autoimmune disorder that targets those hemidesmosomes. And so what you can imagine happens from that is you get destruction, and now you have a layer of potential space where that destruction happens. What are you going to get from that? You're going to get a blister. And this is what's known as bullous pemphigoid. And you've got detachment of the epidermis from the basement membrane. Now, unlike pemphigus, where you only have two layers above that stratum, the stratum spinosum, with bullous pemphigoid, you've got the entire epidermis above where the blistering is taking effect. And so these are going to be much stronger, firmer blisters, whereas with the pemphigus, they're very fragile blisters, and you'll see that when you look at the skin. So this is a blister that you see in bullous pemphigoid. Do you know just from this? No, you do not. As a matter of fact, I was a few weeks ago, I was trying to open a container, and I was really stubborn about it, and I kept trying to open it. Next morning, I woke up with a massive blister. It looked very much like this. So you don't necessarily know it's bullous pemphigoid from this. Do you know this is bullous pemphigoid? Yes, you do. So notice you've got some blisters here, and then you also, anytime you look at a patient with a blistering disorder, you're always going to see some blisters and then some places where the blisters have ruptured. So you'll see various stages. Here's another one. So you can see again here, very tense bullae. And then these areas that where the blisters have ruptured. And the big problem with this and any of the other blistering disorders is the risk of infection. So obviously you've got desquamated skin here, can easily become infected. So if you did immunofluorescence on bullous pemphigoid, you'll find linear deposits of IgG and or C3. Remember, IgG will initiate the classic complement pathway, and so that's ultimately going to lead to C3 migration. And so what you're looking at here is epidermis up here, dermis down here, and this is the dermal-epidermal junction, which is exactly where the pathology happens in bullous pemphigoid. So USMLE loves to throw this at you when they talk about bullous pemphigoid. You'll need to know it's IgG that's depositing at the dermis-epidermal junction. Nikolsky sign also gets thrown out a lot on the USMLE. Now, what Nikolsky's sign is, you'll take something like a pencil eraser, right? And you'll take it along the side of the blister. And what you're trying to do is you're trying to separate the layers of skin apart from one another, and in effect, grow the blister. And what that's telling you is if you take with just gentle light traction and you're able to grow the blister, what that's telling you is you've got a very weak dome of the blister. And that corresponds with Pemphigus vulgaris, because remember, you only have two little layers of epidermis that form the roof of that blister. On the other hand, with bullous pemphigoid, you have the entire epidermis. It's a lot harder to separate those layers. So with Pemphigus vulgaris, you'll be able to grow the blister. That's Nikolsky's sign. So Pemphigus vulgaris will be Nikolsky positive. Bullous pemphigoid, you won't be able to do that because the site of pathology where you've got your blister is much deeper, so it'd be much harder to separate the skin. So this is Nikolsky negative. All right. Hypodermis is the deepest layer of the integumentary system. It's also known as the superficial fascia. It basically anchors the dermis and epidermis to the underlying structures. And it does blend together with the deep layer of the dermis, the reticular dermis. So it's not very distinct. What you do notice with the hypodermis is that it's got a lot of fat. And this is exactly where you store your body fat. So the amount of fat to connective tissue really just varies based on your body composition. So bigger people are going to have more fat. That's where they store it. Whereas smaller people have relatively more connective tissue. The hypodermis houses the base of the hair follicles and the sweat glands, as well as larger arteries, veins, and nerves. Not a whole heck of a lot that goes wrong in the hypodermis compared to the dermis and epidermis. You can get infections, you can get bruising, but not a whole lot of real unique eye-popping stuff that goes on in the hypodermis. Note that the hypodermis is where you inject some medications like insulin and stuff. It's very richly vascularized, so it is a good way of getting insulin into your body. And that's all I've got for you for part 1.